Hello, my name is Kristen Dawson, and today I'll be talking about opioid use in adolescents. I have no commercial financial relationships to disclose. I would like to acknowledge the Kentucky Kids Recovery Grant for funding this educational module in support of the Adolescent Health and Recovery Treatment and Training Project's mission. Ahartt aims to provide Kentucky youth with evidence-based substance abuse treatments and to train providers on best practices in the treatment of adolescent substance use disorders. Today's educational module aims to advance the learner's knowledge regarding opioid use in youth 18 years and younger. Our specific objectives for this module include a review of the national and state level prevalence rates of prescription opioid and heroin use in youth, a discussion of the morbidity and mortality associated with opioid use in adolescents, and finally, we'll try and identify the treatment modalities available for adolescent opioid use disorder. In doing so, we'll discuss the limited but emerging studies of detoxification and maintenance medications for adolescents who have an opioid use disorder. The expected outcome for this talk is that clinicians will be motivated to screen for opioid use in their adolescent patients, that they'll talk to parents about the availability of prescription opioids in the home and how to reduce risk of opioid misuse in their teens. Finally, I hope that you'll be prepared to discuss treatment options for adolescents once they have been diagnosed with an opioid use disorder. Okay, so for those of you who live in Kentucky like I do, you may already be aware of what's called hillbilly heroin, the nickname given to the prescription opioid OxyContin. My first up-close encounter with patients struggling with prescription opioid abuse was as a medical student spending the summer working with a family practitioner in eastern Kentucky. One morning, I arrived to her clinic to see 2 police cars parked outside and soon found that the clinic had been robbed the night before, and the only items found missing were prescription notepads. The opinion of the local police was that the burglars were interested in obtaining prescription opioids. A significant portion of that primary care practice included coal miners with chronic pain, and many of those patients expressed their need to continue on prescription opioid medications just to keep working or cope with the chronic pain that had incurred by years spent down in the mines. I recall a lot of discussions with the 80-year-old primary care provider about non-pharmacological treatment options for chronic pain. She was certainly concerned about opioid addiction, but in large part unsure of how to help her patients given some of the limited resources in her rural community. So fast forward to 2016, and it is pretty difficult to go even a couple of days without hearing about the prescription pain medication and heroin epidemic here in Kentucky and across the United States. There's a growing awareness of opioid use in this state and its devastating effects on its communities. Just a sample of the headlines in my state include coverage of a civil lawsuit against the drug maker of OxyContin, recent legislation to enforce a prescription drug monitoring program called CASPR, and concern about misuse of the very medications that are being utilized to treat opioid use disorder. All right, so let's dive into our first objective, looking at the prevalence of opioid use in adults and compare that to youth. Let's move beyond newspaper headlines and take a look at the data regarding the opioid epidemic. The CDC released a report in July of 2015 regarding data collected from the National Survey on Drug Use and Health and the National Vital Statistics from 2002 through 2013. It's quite clear that heroin use and heroin overdose deaths are on the rise in the United States. In fact, during that 11-year span, the heroin overdose death rate nearly quadrupled, rising from 0.7 deaths to 2.7 deaths per 100,000 persons. There has been a 150% increase in heroin use disorder from 2007 through 2013. A recent update to this data came out in a CDC Morbidity and Mortality Weekly Report regarding drug overdose deaths data for 2014. Unfortunately, this trend toward higher rates of heroin overdose deaths has continued. Again, the rate was 0.7 in 2002, rose to 2.7 by 2013, and now has climbed even higher to 3.4 deaths per 100,000 people. So you might be wondering, who are these new heroin users? It appears that between 2002 and 2011, there wasn't any demographic group immune from the increase in heroin initiation, but the rates were highest for first-time use if you were a male, a young adult, non-Hispanic white, with a low household income, living in the Northeast. And not surprisingly, most of the heroin users had started off misusing prescription opioid pain relievers. Use of other drugs is really the rule for heroin users, with 96% of past-year heroin users having used at least one other drug, and 2/3 of them having used 3 or more different drugs. The demographic profile of an individual who moved beyond experimentation or occasional use of heroin to the development of a heroin use disorder is very, very similar. So again, you have males who are young, non-Hispanic whites, living in a large urban area with a low income, with no health insurance or Medicaid. And individuals with opioid pain reliever abuse or dependence had the highest risk of heroin abuse or dependence, followed by those who were using cocaine, marijuana, and finally, alcohol. So far, we've talked about the rising trends in overdose deaths and heroin use in the United States. We know about the demographic subgroups that are more likely to initiate heroin, as well as the profile of the heroin-dependent individual. But what might be some of the factors causing the rise in heroin use? Well, rising rates of heroin use in the United States have been associated with just an increased availability of heroin. So the DEA has seized 4 times the amount of heroin at the southwest border in 2013 as compared to 2008. So if the assumption is that more heroin is entering the country, more is probably widely available, and it stands to reason that the cost of the product may be driven down. The Office of National Drug Control Policy has reported that the average price of heroin in the United States has decreased, while the purity has increased. So for instance, in 1981, the price per pure gram of heroin was $3,260 at 10% purity. By 2000, the price had dropped to $611 with a 39% purity. And as recently as 2012, the price is down further to $465 with 31% purity. Heroin's move to a cheaper, more readily available, and purer drug has likely implications for increased rates of opiate use disorder and overdose deaths. The CDC reports that in 2014, 61% of all drug overdose deaths in the country involved some type of opioid. Certainly, the morbidity and mortality associated with increasingly prevalent opioid use disorder has become a national public health crisis. While the national age-adjusted drug overdose rate in 2014 was 14.7 deaths per 100,000, the state of Kentucky has the very unfortunate distinction of remaining in the top 5 states for drug overdose deaths with a rate of 24.7. West Virginia is 35.5, New Mexico 27.3, New Hampshire 26.2, and Ohio 24.6. Also struggle with overdose rates higher than the rest of the nation. Zooming our lens in closer to counties within the state, we find that there are regions that are more heavily impacted by drug overdose deaths. Recall that the national rate is 14.7, and take note of these southeastern Kentucky counties experiencing rates above 40 deaths per 100,000 persons. So I spoke to a group of family practice residents in Perry County, and they unfortunately were not at all surprised to learn that they were working in what I would call the overdose belt of our state, if not the nation. So what can we do about the rise in heroin? The CDC's made some specific recommendations to try and address the rise in heroin use and the rise in overdose deaths. Some of those recommendations include a concerted effort to reduce opioid pain reliever abuse because, again, it's so closely tied to progression of heroin use disorder. That might involve state prescription drug monitoring programs trying to reduce inappropriate prescribing of prescription opioids, early identification of patients with problematic use, as well as a move towards improved access to substance abuse treatments, which may include medication-assisted treatments, and finally, an expansion of the overdose recognition and response training that might involve naloxone to treat opioid overdose. I'm going to share with you a little bit about a patient that I met during my child psychiatry fellowship. Rachel was about 15 when I met her on our inpatient adolescent unit, and she presented with recurrent depression, anxiety, and suicidality. Following her stay, she and her grandmother asked to be followed in my outpatient clinic, despite some distance between their home in rural southern Kentucky. I really enjoyed working with Rachel. She described herself as an old soul and often wore t-shirts featuring classic rock bands. She had a long-term boyfriend who was a heavy marijuana user, but Rachel herself had always sworn off drugs, citing the problems it had caused for both of her parents. One of the most poignant sessions with Rachel occurred shortly after her mother's death. Rachel wanted me to tell her about the medications that were listed in her mother's autopsy report, as she tried to make sense of the tragic overdose on opioids and benzodiazepines. So there's always going to be patients that you wonder about when they are lost to follow-up, and Rachel is at the top of that list for me. Her maternal grandmother called me on the phone, panicked, because Rachel had started spending time with older kids in the area. She'd been taking money, possibly some of her great-grandmother's pain medication. The urgency and distress was what you might expect from a woman who had just buried her own daughter as a result of opioid addiction. But in hindsight, there are a couple of things I wish I had done differently. So although I had previously spoken to this family about locking up medications, I certainly wish I had double-checked that prescription pain medications were safely secured following Rachel's mother's death. I now know about naloxone rescue kits and would probably have recommended one for this home. Finally, and most importantly, I really do wish I'd used more motivational enhancement techniques when I did meet with Rachel. I allowed some of my own anxiety about her possible experimentation with prescription opioids take over during that last appointment. I really wish I'd been a little bit more empathic about her ongoing grieving and less confrontational about her possible drug use. Instead of rolling with the resistance Rachel expressed during that session, I engaged in more of a power struggle and ultimately lost because she never returned to the clinic. I hope that those of you watching this module will find it helpful as you encounter youth who have just started using opioids or those who have progressed to a full opioid use disorder. This process of poring over the literature on the topic has certainly been an enriching one for me, as I have a better understanding of what I can do for my patients based on the most current research. I'm also motivated to be a part of moving our knowledge base forward, given that there still are some gaps in our understanding about how best to treat young, opioid-dependent patients. Certainly the focus of this educational module is on adolescent opioid use. So we've talked about national and statewide concerns regarding increased use of heroin and opioid-related overdose deaths. But what's happening to youth as this national crisis looms? So the Monitoring the Future data is headed up by investigators at the University of Michigan and aims to take stock of the American teenager's substance use. The very recently released data from 2014 involves surveying 41,600 8th, 10th, and 12th graders across the country. And despite the sobering trends related to heroin use among adults nationwide, there has been an overall decreased annual prevalence of heroin use among youth. So peak heroin levels for students occurred among 8th graders in 1996 at 1.6% and has since declined in all 3 grades since that time. Rates dipped below 1% between 2005 and 2010 and further declined to the current rate of 0.6% from 2011 through 2014. The Monitoring the Future study also inquired about non-medical use of prescribed opioids in youth. I spoke earlier about the risk of prescribed opioid misuse and its association with the development later on of heroin. Again, a very hopeful trend has been occurring in prevalence rates of non-heroin narcotics like OxyContin and Percocet from 2009 through 2014, wherein the annual prevalence among 12th graders has declined from a peak of 9.5% in 2004 down to 6.1% in 2014 and further to 5.4% in 2015. The Monitoring the Future study authors point out in particular that despite reports of increased heroin use among secondary school students, at least it appears that the use of heroin and of other narcotics both have been declining in parallel for the past 5 or 6 years, with no evidence of any overall displacement from use of one to the use of the other. So, prescription opioid use prevalence rates among high school seniors is around 6%, and that's compared to much more commonly used alcohol at 60%, marijuana at 35%. So what kind of specific concerns should we have about those 6% of high school seniors who have misused prescription opioids? That leads us to talk about the morbidity and mortality associated with opioid use specifically in youth. So certainly at the top of the list of concerns remains the risk of overdose death in youth. But what other additional risks do these youth face as compared to those misusing substances other than opioids? A group of researchers in Baltimore recruited treatment-seeking adolescents between 14 and 18 years of age who had an opioid use disorder, and they compared them to those seeking treatment for cannabis or alcohol use disorders. Compared to the non-opioid users, the opioid use disorder group was more likely to be Caucasian and to have dropped out of school. The cannabis, alcohol, and opioid use disorder groups had very similar criminal behaviors, with the exception that the opioid use group was more likely to be involved in forging checks and stealing. All of the groups had high rates of co-occurring psychiatric disorders at around 80%, including, most commonly, conduct disorder at 50%, major depressive or generalized anxiety disorders at 40%. However, the severity of the depressive episode for the opioid users trended higher than that of the other groups. All groups participated in high-risk sexual behaviors with no significant differences in rates of multiple partners or unprotected sexual activity. Arguably, the most concerning finding in the opioid use group was the presence of IV drug use at 41%, with nearly half of those IV drug users sharing needles in the previous month, putting those opioid use adolescents at a very high risk for HIV and hepatitis C infections. So what do we know specifically about adolescent heroin users? Well, the answer is not nearly enough, but there is some research that is focused specifically on the adolescent population, including a 2002 review on adolescent heroin use and the description of treatment options and the clinical characteristics of those youth. This older study characterized adolescent heroin users as delinquent and dependent upon multiple substances. There was evidence that neighborhood, social, and economic conditions influenced the probability of becoming a heroin user for youth, and that the heroin users were more likely to be a part of a single-parent household and to have used marijuana previously. As well, there was increased levels of family dysfunction, and polysubstance use was found in this series of 100 adolescent heroin users. So before I delve into the evidence-based treatments for adolescents with opioid use disorder, I'll briefly remind you about the current treatments for adults. So the standard of care for treatment of adults with opioid use disorder typically involves an initial detoxification treatment, followed by the use of psychosocial therapies, with the use of a maintenance pharmacologic treatment. The CDC is advocating for improved access to evidence-based treatments, and that includes medication-assisted treatment. The 4 medications with FDA approval for opioid use disorder in adults includes methadone, buprenorphine, the combination of buprenorphine with naloxone, and naltrexone. And additionally, it should be noted that naloxone, which is an opioid antagonist, can be used to emergently reverse an opioid overdose. And we just heard that the CDC is advocating for increased recognition of opioid overdoses and access to naloxone for that treatment. As I mentioned previously, there are few clinical trials involving adolescents with opioid use disorders. So at this point in time, treatment of an adolescent with opioid use disorder is likely to involve opioid detoxification with or without medication assistance, followed by psychosocial interventions for substance use disorder in either an outpatient or residential setting conducted individually or in groups. Since opioid replacement therapy is considered first-line treatment for adult opioid use disorder, we will discuss the 2 clinical trials exploring this treatment modality in an adolescent population. Certainly, there is a need for additional research regarding opioid replacement therapies for youth. So let me take a moment to briefly describe the 3 different opioid drug receptor types, as it will come up again and again in our discussion of pharmacologic treatments for opioid use disorder. The first type of interaction in the brain's mu opioid receptor is one in which the receptor is fully activated, and that happens with full agonists like heroin and morphine. When the mu opioid receptor is turned on, the result is an analgesic effect and a euphoric effect. The second type of interaction is just the opposite of a full agonist. It's that of an antagonist. It's as though a lock is placed on the mu opioid receptor so that there are no opioid effects and other drugs can't activate the receptor as long as the antagonist is bound. So naloxone and naltrexone are examples of opioid antagonists. Finally, there's a partial agonist effect on the opioid receptor. And buprenorphine is an example of a partial agonist that will bind to the opioid receptor and in doing so activate analgesic and euphoric properties. But the partial agonist is limited by a ceiling effect. That is, at a certain point, increasing the dose of a partial agonist no longer produces the opioid's effect. As well, while that partial agonist is at the receptor, it does block the action of a full agonist from occurring. So for that reason, we think of partial agonists as having a better safety profile as compared to the full agonists. There's a lower potential for abuse, lower level of physical dependence, decreased likelihood of an overdose secondary to respiratory depression, and then there's also some decreased discomfort if you withdraw from that medication. The combination drug buprenorphine naloxone is really pretty interesting. So buprenorphine is a partial agonist, and it's absorbed much more efficiently by the sublingual route as compared to the GI tract, while naloxone, an opioid antagonist, has the opposite absorption profile. So if the buprenorphine naloxone sublingual medication were to be altered somehow by an individual and injected, that naloxone antagonist action would take over, not only preventing an opioid euphoria state, but potentially also inducing a withdrawal syndrome. Okay, so you have a better idea about how methadone, buprenorphine, naloxone, and naltrexone work. So let's move forward with an overview of the evidence-based treatments for opioid use disorder in adolescents. You may recall that when discussing the standard of care for treatment of adults with opiate use disorder, the initial step involved detoxification. So let's first focus on that initial treatment of opioid use disorder in adolescents, detoxification. Consider a 17-year-old who reports daily IV use of heroin and is now seeking treatment. What do we know about how best to help this youth discontinue use of heroin so that he or she can proceed with a longer-term phase of their treatment? A recent Cochrane review set out to try and answer this very clinical question. The reviewers searched for randomized, controlled clinical trials involving placebo, pharmacological intervention, or psychosocial intervention for adolescents 13 to 18 years of age pursuing detoxification from opioids. Only 2 trials emerged with a total of 190 subjects. The most common medication used for adult opioid use disorder detoxification is methadone. Recall that was a full opioid agonist. But detoxification can also involve buprenorphine, that partial opioid agonist, as well as clonidine. Prescription of methadone to patients under 18 is highly restricted due to specific requirements that must be met in order to prescribe it. There were no methadone studies in adolescents for opioid detoxification. Opiate-dependent youth, ages 16 years and older, may be prescribed buprenorphine by a prescriber specifically trained and licensed for buprenorphine. So let's talk specifically about these two studies focusing on adolescent detoxification treatment, including an investigation of buprenorphine versus clonidine, as well as a study of buprenorphine combination naloxone. A 2005 study by Marsh and colleagues investigated the use of buprenorphine versus clonidine, a centrally active alpha-2 adrenergic blocker, for detoxification in adolescent opiate-dependent youth. 36 adolescents with opioid dependence, ages 13 to 18 years of age, were enrolled and randomly assigned to one of the medications, in addition to a 28-day outpatient treatment program that included behavioral counseling 3 times a week and contingency management. After the medically assisted detoxification, participants were offered a maintenance treatment with use of naltrexone. The study's main outcomes overwhelmingly favor buprenorphine detoxification. So let's compare retention, opioid abstinence rates, and percentage of participants who went on to the maintenance treatment. For retention, 72% of buprenorphine participants completed the detoxification in its entirety, compared with just 39% of the clonidine group. Opioid abstinence, so 64% mean opiate negative urine samples for the buprenorphine group, compared to 32% in the clonidine group. And finally, the initiation of naltrexone treatment. So again, just as a reminder, a major goal of detoxification from opioids is to transition patients into a maintenance phase of treatment. This particular study offered subjects who completed the 28-day outpatient detoxification a maintenance phase that included ongoing counseling, urinalysis, and medication treatment with the opioid antagonist naltrexone for an additional 2 months. However, all 3 urine samples during the last week of detoxification phase had to be opioid negative, or any 3 consecutive urine samples in the next month in order to be eligible for that aftercare program. 61% of the buprenorphine group participants, as compared to just 5% of the clonidine participants, entered into the naltrexone maintenance treatment. And the authors of this study point out that 60% of the youth in the buprenorphine group went on to naltrexone maintenance treatment, while previous studies have found that only about 10 to 15% of adults with opioid dependence accepted a similar naltrexone treatment. A couple of other treatment outcomes include an HIV risk behavior scale. So both groups reduced their drug-related HIV risk behavior from treatment intake to the end of the first week. Another rating was the adjective rating scale. So both groups experienced significantly decreased withdrawal scores. So to review the findings of this study with 36 opioid-dependent adolescents, those that were offered detoxification with buprenorphine as compared to clonidine were almost twice as likely to stay in treatment long enough to complete the detoxification process and had twice as many negative urine drug screens for opioids. Both the clonidine and buprenorphine detoxification groups reduced withdrawal symptoms and reduced their HIV risk factors. Finally, the buprenorphine group was much more likely to enter into a second phase of treatment with naltrexone. Let's move on to the other study identified in the Cochrane Review of Opioid Detoxification Treatments for Adolescents, and that was a 2008 multi-site trial of 152 youth between 15 and 21 years of age. Rather than comparing 2 different types of detoxification medication, this study randomized the participants to either 2-week outpatient medication detox with buprenorphine naloxone, or a short-term maintenance treatment of buprenorphine naloxone for 9 weeks, followed by a 3-week taper off of the medication. All participants participated in at least 1 hour of individual and 1 hour of group drug counseling per week. Okay, for those of you who may be familiar with prescribing buprenorphine naloxone in adult patients for detoxification or maintenance, the range of dosing in this study for 15 to 21-year-olds are listed below. So for the 2-week buprenorphine naloxone taper, about 31% were maxed at a dose of 2 to 8 milligrams of buprenorphine naloxone, and then the rest maxed at a dose of 9 to 14 milligrams. In the other arm of the study were the short-term maintenance patients, and the 12-week buprenorphine naloxone maintenance dose was 2 to 8 milligrams for about 27% of the subjects. Most of the subjects ranged between 9 and 16 milligrams, and finally 14% of the subjects were dosed at between 17 and 24 milligrams of buprenorphine naloxone. I should also note here that while the study aimed to enroll subjects as young as 14 years of age, the youngest subject that was actually recruited was 15 years of age, and only 18% of the detox group and 16% of the short-term maintenance group were under 18 years of age. So what did the study find? At the end of 12 weeks, only 20.5% of the detoxification group remained in treatment, as compared to 70% of the short-term maintenance participants. During the course of the 12-week study, the maintenance group reported less opioid use, less injection, and less non-study addiction treatment to treat the withdrawal symptoms as compared to the detoxification group. Unfortunately, 4 of the 83 patients who had been hepatitis C negative at study initiation had seroconverted to positive hepatitis C status at week 12. In this study, the youth who completed the 2-week buprenorphine naloxone detoxification were 7.05 times more likely to have relapsed on opiates as compared to those 4 weeks into the maintenance treatment arm. By 8 weeks, the detoxification group was still 5.07 times more likely to have relapsed. However, by 12 weeks, the maintenance group had tapered off of the medication, and it lost its significant advantage as compared to the detoxification group. In addition to a higher percentage of negative urine drug screens at week 4 and 8 for the maintenance group also performed better on secondary outcomes. So those in the 12-week buprenorphine naloxone group were more likely to complete the treatment study, 70 versus 21%, and to attend more of the counseling sessions. The detoxification group was 4.3 times more likely to report opioid use, 6.15 times more likely to report cocaine use, and 3.54 times more likely to report injection drug use. Those in the detoxification group were 13 times more likely to enroll in some other type of addiction treatment outside of the study. Seeking out additional treatments may be an indicator that the detoxification subjects perceive themselves as being at risk for relapse. Urine drug screening at 6, 9, and 12 months continued to favor the short-term maintenance group with an odds ratio of 2.65, but relapse rates were high for both, with a mean rate of 48% in short-term maintenance subjects versus 72% for the detoxification subjects. The authors reported that there were no serious adverse events related to administration of buprenorphine naloxone, and the most common adverse effect were headaches, with 16 to 21% of subjects. The authors also reported on outcomes that really drive home the point that effective and timely treatments for opioid-dependent youth are desperately needed. Again, during the course of the study, 4 out of the 83 previously hepatitis C negative patients seroconverted to hep C positive. And finally, one of the 74 youth who started the 12-week buprenorphine naloxone group dropped out after 3 doses and was later identified in obituary, with the cause of death being methadone overdose. This study represents a huge undertaking at 6 different sites across the country in an effort to find safe and effective treatments for opioid dependency in the youngest users. The average length of opioid use for these youth was just 1.5 years, but keep in mind that these subjects had to have evidence of physiological dependence. So that means that even though the participants had been using opioids for a relatively short amount of time, they had experienced either tolerance for the drug or typical opioid withdrawal symptoms. So remember that tolerance for a substance involves having to increase the amount of the drug to get that same high or experiencing a diminished effect of the drug if using the same amount of it. Typical opioid withdrawal symptoms include nausea, vomiting, muscle aches, dilated pupils, sweating, goosebumps, diarrhea, insomnia, yawning, fever, runny nose or watery eyes, and an overall dysphoric state. I've read this study many times over the past couple of months. Depending on the day and my level of optimism, I'm either disheartened by the findings or grateful for the lessons learned. The promise of buprenorphine naloxone as an outpatient, relatively short-term treatment for youth who have recently crossed over into opioid dependency was certainly really appealing. The ultimate goal is, of course, to intervene early and to change the trajectory of illness for adolescents and young adults, including trying to avoid the risk of an opioid overdose, infection with hepatitis C and HIV, criminal activity, loss of educational and job attainment, and so on. But this trial did not find that a short-term intervention with buprenorphine naloxone reduced opioid use at the end of 12 weeks, which really is too bad. Certainly the question of whether or not 12 weeks of buprenorphine naloxone could have been enough to treat young adults and adolescents with opioid dependence needed to be answered. So what's more is we have evidence to show that when the youth are maintained on the buprenorphine naloxone, so prior to being tapered off of it, there is a significant reduction in opioid positive urine drug test, in self-reported opioid and cocaine use and injection needle use, as well as improved compliance with substance abuse treatment. For me, that's really a silver lining. Here's what the study authors had to say. These data suggest that once DSM-4 criteria for opioid dependence with physiological features are met, the course of addiction appears similar regardless of its length, and that clinicians should be in no hurry to stop an effective medication simply because the patient is young and has been addicted for a short time. There really is an urgent need to conduct clinical trials of youth with physiological opioid dependence and long-term maintenance therapies. In the meantime, I think it is reasonable to consider the maintenance use of buprenorphine naloxone in youth who, despite their age, have developed physiological dependence on opioids and who also have a history of needle sharing, unprotected sex, previous opioid overdose, and significant psychiatric comorbidities. We will see that a follow-up study lends support to this patient profile as being particularly likely to benefit from the use of buprenorphine naloxone. A follow-up paper to this detoxification versus short-term maintenance with buprenorphine naloxone study was published in 2011. The goal was to take a look at the data and determine if there were certain traits or conditions among those opioid-dependent youth that might predict opioid abstinence with the treatment. And given the limited evidence for pharmacologic treatments for opioid-dependent youth, clinicians, patients, parents alike are considering a buprenorphine treatment will certainly benefit from this additional assistance in assessing its potential benefit. Dr. Subramaniam and her colleagues found the following predictors for opioid abstinence. So a previous 30-day IV drug use of opioids, cocaine, or amphetamines. A more active medical and or psychiatric problem prior to entering into the treatment. A higher degree of internalizing symptoms like anxiety and depression prior to starting the treatment. Having an opioid negative urine really early on in the course of treatment, so like in week 1 or 2. attending at least one therapy session early on in treatment, in general adhering to medication early in the treatment, having elevated liver enzymes, receiving a non-study treatment during the 12 weeks, receiving a non-study medication, attending more counseling sessions during the 12 weeks, having more medical and or psychiatric problems at the very last visit, and finally completion of the full 12 weeks of treatment. So of note, the type of opioid use, whether it was heroin, non-heroin prescription, or both, was not a predictor of the response to treatment. Rather, the severity of the opioid use disorder, as defined by presence of IV drug use, medical and psychiatric comorbidities, were predictors of benefit from the pharmacologic treatment. So clinicians should pay particular attention to whether or not an early drug screen is negative, the patient is accessing additional medications or services, and how long a patient remains in treatment, as these are signs that will predict abstinence. Okay, so let's move on to the adolescent treatment phase of maintenance. Earlier, I mentioned that a Cochrane review investigated studies for pharmacologic detoxification of opioid-dependent youth. A second Cochrane review was published in 2014 by many of those same investigators with a new focus on maintenance treatments for opioid-dependent adolescents. The review examined randomized controlled clinical trials of any type of maintenance pharmacological treatment for opioid use disorder in adolescents. And again, there were only 2 trials identified, one of which we just discussed. The 2008 study of buprenorphine naloxone 2 weeks detox versus the short-term maintenance with buprenorphine naloxone was cited. The only other maintenance study was published back in 1973, and it compared a 16-week maintenance treatment for LAM versus methadone followed by detoxification. So LAM is no longer available because it had some life-threatening cardiac adverse effects. And methadone is typically not an option in the United States for patients under 18 years of age due to some significant restrictions on its prescription. An opioid-dependent youth seeking methadone treatment would have to access a specialized methadone clinic and then demonstrate that they have consent from their legal guardian. But more burdensome than that is the requirement that the youth must have demonstrated a failure of 2 prior treatments within a 12-month period. And finally, the treating physician has to verify that the youth remains physiologically opioid dependent. In reviewing these studies, you may start to appreciate why there's a debate regarding whether or not adolescents with opioid dependency should be recommended for pharmacotherapy treatments for detoxification or for maintenance therapy, despite it being standard practice for adult patients. Certainly, we know that there is significant morbidity and mortality associated with opioid dependence and that effective treatment options are desperately needed. But at this time, there simply is not a lot of clinical evidence to draw conclusions from regarding opioid maintenance treatments for the adolescent population. As well, we must also acknowledge that the adolescent brain continues to mature through the mid-20s, and any impact that opioid agonist maintenance therapy might have on brain development is unknown. Finally, there are concerns regarding the possible diversion or abuse of these opioid agonist treatments, and I'm going to try and address that last concern in the next few slides. There are certainly concerns in the community regarding the misuse of opioid replacement therapies, including the full opioid agonist methadone and partial agonist buprenorphine. So on the one hand, we have evidence that medication-assisted treatments can be life-saving, but we also have experiences of community members who have had friends or family members that they may be aware are misusing methadone, or perhaps who have even succumbed to an overdose involving the drug. Researchers at the University of Kentucky are involved in studies that may shed some light on what is happening throughout the state with respect to diversion or abuse of medications used in the treatment of opioid use disorder. The Kentucky Opiate Replacement Treatment Outcome Study Trend surveys adult clients who entered into any opioid treatment program in the state. when they first entered, and then a sample of participants are surveyed 6 months later. The data from Kentucky demonstrates a large increase in the number of clients presenting with heroin use, an increase from 8.4% in 2007 up to 48% in 2013. The misuse of prescription opioids ranged from 79 to 88%. And there's some definite positive news with respect to trends in non-prescription use of methadone prior to entering into a treatment program. And that is that abuse of methadone in the community has declined from a high of 40% in 2007 down to 21.4% in 2013. However, there has been a rise in the non-prescribed use of buprenorphine in the state, with an increase from just 2% in 2007 up to 20% in 2013. What is interesting is that just 6 months after patients enter into treatment at a Kentucky opiate treatment program, the levels of non-prescribed use of each opiate agonist dropped to levels of 4% or less. Heroin use dropped from 48% down to 4%, prescription opioids from 79% down to 3.7%, buprenorphine 20.7% down to less than 1%, and methadone 21.5% down to 1.4%. So certainly it is unfortunate that prescription therapies are used illicitly in the community. And again, methadone and buprenorphine at rates of about 20% prior to entering treatment. Yet, the controlled clinical use of opiate replacement therapies in a treatment setting does appear to have a huge impact in reducing the illicit use of opiates, with likely implications for reduction in criminal behavior, risk of HIV and hepatitis C transmission, and accidental overdose. So what about the diversion of medications within the adolescent population? Well, a similar study investigated adolescents in Kentucky seeking treatment for substance abuse. The AKTOS conducted a study among Kentucky youth between 11 and 17 years of age seeking treatment at a publicly funded substance abuse facility. The participants were surveyed when they started treatment and then 12 months later by self-report. This data set does not provide information regarding whether or not opiate replacement treatment was offered to the adolescents, but what it does demonstrate is that treatment-seeking youth endorsed misuse of methadone at 4.7%, buprenorphine at 5.7%, and heroin at 3.2%. 12 months following their treatment, all illicit opioid use declined, though again, the type and the duration of treatment wasn't specified and probably varied across the sites. Illicit prescription opiate use dropped from 24.3% down to 5%, and heroin use dropped from 3.2% to 1.7%. This demonstrated misuse of buprenorphine in the community by adults and adolescents alike does raise questions for me. So certainly when I was first trained on buprenorphine naloxone, it was promoted as the safer maintenance therapy for opioid use disorder. The partial agonist properties of buprenorphine meant that patients were less likely to achieve a high and to experience the life-threatening respiratory depression. The addition of naloxone meant that attempts to inject the medication would precipitate an opioid withdrawal. The Cortos and the AKTOS data clearly indicates that buprenorphine is being used without a prescription here in Kentucky. Earlier in this talk, I mentioned the 4 FDA-approved medications for treatment of opioid use disorder in adults. We've touched on opioid agonist methadone, the partial opioid agonist buprenorphine, as well as combination buprenorphine naloxone. We haven't directly discussed adolescent studies involving naltrexone, and that's because there haven't been clinical trials involving adolescents. We do have a case series, however, that was published in 2010 involving the once-a-month injectable form of naltrexone. 16 patients, ages 16 to 20 years, were treated in an outpatient, adolescent, and young adult drug treatment program with the long-acting naltrexone. Patients received 1 to 2 group counseling sessions per week, 1 individual motivational enhancement with CBT therapy visit per week, in addition to physician appointments. Patients had previously participated in a residential detoxification program with buprenorphine taper and then offered the various treatment options as they transitioned into outpatient treatment. Those that chose the long-acting naltrexone remained in residential treatment following the buprenorphine taper, as oral naltrexone was started. If the daily naltrexone dosing was well tolerated, patients were injected with a long-acting medication prior to discharge. 63% of the returning patients participated in treatment for the next 4 months. 69% of the patients substantially reduced their opioid use or achieved abstinence. And 56% had substantially decreased opioid use, experienced an improvement in one or more area of their life, so school or work, and had no drug-related problems at 4 months. So again, there are no head-to-head trials comparing the use of antagonist treatment like long-acting naltrexone to an agonist therapy, but in general, the authors of this study point out that when presenting medication options to patients at their treatment center, many of the patients' parents were enthusiastic about naltrexone's ability to competitively block opioid receptors, and this provided a sense of reassurance to those concerned family members. As well, the authors report that medication adherence is problematic in this population, and patients may decide to stop a daily maintenance therapy and then quickly achieve a high from illicit opioids. This monthly coverage of long-acting naltrexone may be advantageous from this standpoint. However, it should be noted that many insurers do not provide coverage for long-acting naltrexone, and the out-of-cost expenses could represent a significant barrier to its use. I recently spoke with Dr. Leslie Haversham, a psychiatrist at Indiana University, who has had excellent clinical responses when working with youth with opioid use disorder and injectable naltrexone. Her experience has been that the medication has been of particular benefit in patients who may not be experiencing physiological dependence yet, but nonetheless present with IV heroin use and significant functional impairment related to its use. Okay, so let's go over some key points regarding adolescent treatment of opiate use disorder. So the standard of care for adults with opiate use disorder includes opiate detoxification, followed by the use of maintenance medications with psychosocial intervention. The FDA-approved medications for adults includes methadone, buprenorphine, the combination buprenorphine with naloxone, and naltrexone. For adolescents, there's no consensus regarding the use of maintenance medications due to too few clinical trials. But after reviewing the limited evidence, it appears that buprenorphine detoxification may be superior to clonidine detoxification for adolescents with opiate use disorder. A short-term buprenorphine naloxone maintenance therapy benefited opiate-dependent adolescents prior to tapering. So future studies should focus on longer maintenance therapies of buprenorphine naloxone. Some of the baseline predictors of abstinence with buprenorphine treatment included the use of IV drugs and comorbid medical and psychiatric illnesses. The during treatment predictors of abstinence included an early negative urine drug screen and engagement in the additional therapeutic services and medications. Finally, long-acting naltrexone has been shown to be promising in case series, but must also be investigated in future randomized clinical trials. Given the risk of overdose, hepatitis C, and HIV infection that can accompany physiological dependence of opioids, there may certainly be patients under 18 years of age for whom buprenorphine naloxone maintenance treatment represents a life-saving treatment option when combined with intensive psychosocial interventions. Certainly, additional studies are warranted, but this option should be carefully considered with these highest-risk patients and their caregivers. I've touched on a number of barriers to effective treatment for opiate-dependent adolescents. Retention in psychosocial interventions is low, the evidence base for pharmacological interventions is small, the availability of specialty tracks for adolescent opiate use disorders is limited, and some promising medications may be cost prohibitive or age prohibitive. Meanwhile, there are adolescents with opiate dependency at risk for accidental death by opioid overdose. I've recently been learning quite a bit about the opioid reversal agent naloxone, also known as Narcan. SAMHSA has released a publication that they're calling an opioid overdose toolkit, the purpose of which is to is to disseminate key strategies to prevent overdose deaths. Not surprisingly, a key intervention is to provide access to naloxone in a timely manner. Emergency medical services have provided resuscitation with naloxone, but certainly there may be cases in which EMS is not contacted at all, or perhaps unable to reach someone with respiratory depression due to an opioid overdose in time. So there's a movement underway to provide naloxone rescue kits to persons at high risk for an opioid overdose death. Dan Wormling is a pharmacist and researcher here at the University of Kentucky who has been strongly advocating for distribution of naloxone kits to high-risk opioid users. He compares prescription of naloxone to an opioid-dependent patient to the role that allergists play in distributing EpiPens to patients with a history of anaphylaxis. The importance of this could not have been more clearly illustrated to me as it was by a patient I recently saw in clinic. So I recently was working with a middle-aged woman who's hepatitis C positive and has a very long history of opioid use disorder. She had been in and out of jail for several years, and my first encounter with her was just as she had been released from jail. She'd been court-ordered to residential treatment, but decided to leave treatment prematurely, and she declined to return to that residential treatment facility, but she was willing to accept a referral to a buprenorphine naloxone clinic. Unfortunately, she didn't show up to that clinic, and when I finally saw her again, she reported that she had experienced a serious heroin overdose. The two friends that she was with did not call 911 because they knew of an active warrant for her arrest. They performed CPR, and eventually she regained consciousness. Minutes later, she called the only sober person she knew and moved in with that individual, and the experience prompted her to start an opioid treatment program within the week. This patient happened to be fortunate to survive an overdose, and the event appeared to provide additional motivation for her to enter into a more intensive substance treatment program. Certainly, there are unfortunate opioid overdose deaths that may be prevented if access to naloxone becomes more widely available in high-risk communities. Here in Kentucky, SB 192 went into effect in March of 2015. The law provides authorization to pharmacists to initiate the dispensing of naloxone in an effort to prevent opioid overdose deaths. The pharmacists complete an educational certification process and work within a physician-approved protocol. Naloxone can be dispensed as an intranasal spray or via an intramuscular route. And there's also an auto-injector that can talk a layperson through the steps needed to administer the naloxone medication in an emergency. So if you're treating opioid-dependent youth, consider talking to your patients and their families about having a naloxone rescue kit at home, and consider having a kit available at your treatment facility. If you'd like to learn more about naloxone prescribing, take a look at the SAMHSA overdose kit at the end of this module. As well, we'll be releasing a continuing education module on our Ahartt website, as well as through CE Central, that covers naloxone prescribing in great detail. Okay, so we've wrapped up discussion of the various psychopharmacologic interventions used in adolescent opiate use disorder. We'll next talk about psychosocial treatments. And unfortunately, studies regarding these psychosocial interventions, specifically for opiate use dependence in adolescents, rather than for the general treatment of drug and alcohol use in youth, are really pretty limited. A 2004 study did investigate outcomes of adolescents with and without heroin use who participated in a short-term residential treatment program. The heroin users were found to have higher severity of drug use, higher rates of impairment in functioning and psychological distress when they entered into treatment as compared to those non-heroin users. Certainly, the heroin users responded to the treatment, but that overall increased severity level did persist at 12 months follow-up as compared to the youth using the other drugs. Additional psychosocial treatment studies of heroin-using youth were published back in the 1970s. Clearly, additional work is needed to explore the types of psychosocial interventions most effective in the treatment of opioid use disorder in youth. Some treatment facilities utilize a special opioid use track, but further study on those specialty tracks for adolescents is certainly needed. At the beginning of this talk, I spoke to you about a 15-year-old from Eastern Kentucky who had lost her mom to an accidental drug overdose. Certainly, the rise in accidental overdose deaths related to opioids is alarming within the adult population, as is the increase in heroin use. It's absolutely essential that those of us treating adolescents talk to caregivers about locking up prescription medications that might be in the home. We need to screen for early misuse of prescription opioids in our youth. And finally, for those youth that have already developed an opioid use disorder, we need to help them access treatment and acknowledge that there may be a role for medication-assisted detoxification and opioid replacement treatments, in addition to essential psychosocial interventions tailored to their developmental level. These youth face significant risks for overdose death, hepatitis C and HIV exposures, criminal behaviors, and legal problems, and treatment must be offered as early as possible. Thanks so much for listening to this module on opioid use disorder in adolescents. And again, you can find additional adolescent substance use talks right here on CE Central.